Hey guys, it's Olivia. Welcome back to your endocrinology chapter. In this section, we'll be talking about thyroid neoplasms, so these really fast-growing cells that can either be benign or malignant within your thyroid, but can cause a lot of conditions that show up on step 1 of your boards. And the first of which that I want to talk to you about is thyroid adenoma. So thyroid adenoma is going to be one of these benign conditions. It's usually a solitary growth, so this one area of the thyroid that is growing, this one nodule, and it's usually a cold nodule. So a cold nodule means that it is not producing T3 or T4. It is just a nodule, just a mass within the thyroid. It is usually a cold nodule. However, sometimes it can be a hot nodule where it does produce T3 and T4. And of course, that can lead to hyperthyroidism and thyrotoxicosis. However, for the purposes of step 1, if you see a hot nodule, you should be a little bit more suspicious for something like toxic multinodular goiter. But in this case, we are talking about thyroid adenoma, so it's usually going to be a cold nodule. Thyroid adenoma is follicular, so you're going to see a lot of follicular cells within that adenoma. And then importantly, there's no capsular or vascular invasion, so that's going to be different from something like follicular carcinoma, because follicular carcinoma is going to be malignant and invasive, whereas thyroid adenoma will be benign and not invasive. And that's going to be an important fact for you to know to be able to distinguish between these two on a board style question. The presentation for thyroid adenoma is most frequently asymptomatic. These nodules are usually incidentally found on different scans, different ultrasounds maybe that pass through the neck, and then if we want to follow them up, if we have a high clinical suspicion for malignancy, a fine needle aspiration can be performed to rule out malignancy. But of course, in the case of a thyroid adenoma, this lesion is benign, so it usually does not require treatment. However, if it gets too large and is compressing on certain structures that are near the thyroid, causing things like cough or dysphagia, if we are compressing on the recurrent laryngeal nerve or the trachea, then we might need to surgically resect our thyroid adenoma. So that would be one of the treatments in this case. The next type of thyroid neoplasm that I want to talk about is papillary carcinoma. Now this one is malignant and it is the most common form of thyroid cancer. It has some very particular histology that I think it's really important for you guys to be aware of because it comes up on step 1 a lot. So these are going to be your orphan Annie nuclei and your Samoma bodies. So if you look over here at this first picture, we have an illustration down here of the orphan Annie cartoon, and you can see that the orphan Annie cartoon kind of has these eerie, almost demonic white eyes for all of the characters. And similarly, these cells here have hollowed out centers with these white areas that kind of look like the eyes of the dog or of Annie in this orphan Annie cartoon. So that's why they're called orphan Annie nuclei, and these are very characteristic of papillary carcinoma. Additionally, over here you can see a Samoma body. The Samoma body right here kind of has this onion skinning appearance. It looks like you've dropped a drop of paint into a bucket of water and it's spreading out these concentric rings. These are also commonly seen in the presentation of papillary thyroid carcinoma. And both of these pictures, although they can be seen in other pathologies, are not really seen in most of the other thyroid cancers. So they are going to be helpful for you to distinguish which thyroid cancer we're talking about. So remember, if you see orphan Annie nuclei or if you see Samoma bodies, it is a good bet we are talking about papillary carcinoma of the thyroid. If this is a thyroid question, great to keep that in mind. Risk factors for papillary carcinoma, there's certainly some genetic risk factors. So RET and PTC rearrangements, those genes can certainly increase your risk for papillary carcinoma, as well as BRAF mutations. Childhood irradiation can also increase risk for papillary carcinoma, especially if the child received radiation to the neck for some other type of cancer or to the head for some other type of cancer and got some of those rays kind of going through the neck. So great to look out in a question stem if the patient had a different type of cancer that was treated with radiation in childhood, increasing their risk for papillary carcinoma. Papillary carcinoma is also usually asymptomatic, and we would diagnose it with a fine needle aspiration. That's how we get all these cells that we can look at in histology and then see our orphan Annie nuclei or our Samoma bodies to reassure ourselves that it is papillary carcinoma. And then also we could run some genetic testing as well. And the management for papillary carcinoma, it actually has a really good prognosis and probably has the best prognosis out of the malignant neoplasms that we were talking about here. I've actually organized these neoplasms in descending order of prognosis. So at the top we have our benign thyroid adenoma that has a great prognosis because of course it's benign. Papillary carcinoma also has an excellent prognosis, and as you'll see, these have a worse and worse prognosis as we go down the list. But papillary carcinoma, it has a great prognosis as we have mentioned, and you can treat it with a thyroidectomy, and that that a lot of times is curative. Now, our follicular carcinoma, which is the next carcinoma that we will talk about, is also malignant, and then something that is characteristic of follicular carcinoma is invasion of the thyroid capsule and the vasculature. So if we go over to our image on our right here, you can see that this follicular carcinoma is exiting through the capsule of the thyroid. It has broken through the thyroid capsule, and these cells escape from the thyroid to route hematogenously, frequently to the bone and the lungs. Now, this is really important for you to be aware of, because if you ever see a picture like this where we have all of our follicular cells spraying out of the capsule and into the surrounding space, that is going to be very consistent with follicular carcinoma. It's certainly going to be very different than thyroid adenoma, which does not exit the capsule. So that's going to be an important histology finding for follicular carcinoma. Additionally, you'll see these uniform follicles. You can see a lot of follicles scattered through this picture. It is also associated with the RAS mutations, as well as translocations in PAX8 and PPAR gamma. So those are going to be important genes for you to memorize when we're talking about things that can increase your risk for follicular carcinoma. The presentation is usually asymptomatic. Again, we diagnose with fine needle aspiration, like we diagnose most of our thyroid malignancies. And then we have a good prognosis here. We treat it with thyroidectomy. However, you can see why this prognosis wouldn't be as great as papillary carcinoma because of this potential for hematogenic spread to different routes like the bone and the lungs. Marching down the list here, next we have medullary carcinoma. And something unique about medullary carcinoma is that it involves these parafollicular C cells that can release calcitonin. So if you see elevated levels of calcitonin, that is a great clue that we are talking about a medullary carcinoma. This is another well-differentiated neoplasm. Papillary carcinoma and follicular carcinoma are also well-differentiated, but uniquely, this one involves sheets of amyloid in the stroma. This amyloid stains Congo red. That's a common pattern that you'll see for histopathology. When we are trying to stain amyloid, we'll usually use this Congo red stain. And Congo red, even though it's called the Congo red stain, has apple green birefringence, so directly the opposite, so keep that in mind. And if you look over here on these two images, we have a ton of amyloid, right? We have a ton of this kind of glossy, shiny, smooth area here. It kind of looks like collagen, but here it's amyloid. And then down here on our Congo red stain, you can see these areas of apple green birefringence, and that's the amyloid staining apple green. The blue here is the collagen, so it's really helpful to have this Congo red stain that will cause this apple green birefringence because it helps us distinguish amyloid from collagen. Additionally, it helps us reassure ourselves that we do have amyloid present in the sample, which of course is very suspicious for a medullary thyroid carcinoma. So if you see a ton of amyloid in a picture, or if you see Congo red stain being used with apple green birefringence, it's a good bet we're talking about a medullary carcinoma. This medullary carcinoma is also associated with mutations in the RET gene, as well as the MEN2A and MEN2B syndromes. So you might remember that MEN2A is associated with pheochromocytoma, parathyroid hyperplasia, and medullary thyroid cancer. So that's where the medullary thyroid carcinoma comes into the mix. And MEN2B is associated with marfanoid body habitus, mucosal neuromas, pheochromocytoma, as well as this medullary carcinoma. So medullary carcinoma, MEN2A and MEN2B. Remember, it's the thyroid carcinoma that starts with M that goes with the MEN syndromes, and that is certainly a key fact that is likely to show up on step 1 of your boards. The presentation is still asymptomatic. We're still going to diagnose with a fine needle aspiration, and we're going to stain with Congo red, and then management, we will do a thyroidectomy. And then finally, let's talk about our undifferentiated or our anaplastic carcinoma. As you can tell by the name, this is going to be a poorly differentiated cancer. On histology, you'll see areas of necrosis, hemorrhaging, and giant cells. Over here, you can see this large area of necrosis on our slide, which is certainly suspicious for an undifferentiated or anaplastic carcinoma. The presentation is usually in older patients, and they will often complain of this rapidly enlarging neck mass. So we haven't had an enlarging neck mass in any of these other types of thyroid cancer. That's going to be pretty unique to anaplastic carcinoma. This rapidly enlarging neck mass can cause compression of surrounding structures, which can lead to these symptoms like dysphagia or dyspnea if we compress on that laryngeal nerve, or if we compress on the trachea or anything else that is in the region. It's associated with the TP53 mutation, so that is going to be one of our important tumor suppressor proteins, and when it is mutated, it is not going to be able to do its job as well, so that can certainly lead to this anaplastic carcinoma. And then undifferentiated anaplastic carcinoma carcinoma has a very poor prognosis, and that should make sense to you, right? Because if we have an undifferentiated cancer, it's usually going to be more malignant, and certainly it is in this case. Even with thyroidectomy, this has a pretty poor prognosis, and it's definitely going to be the most dangerous type of thyroid cancer that we have talked about. I know that was a lot of information. Let's quickly recap what we talked about in this video. First, we talked about thyroid adenoma, which is going to be our benign type of thyroid neoplasm that presents with cold nodules. Then we talked about papillary carcinoma, which has the best prognosis of all of the cancers that we talked about. It's characterized by orphan antinuclei or psammoma bodies on fine needle aspiration. Next, we talked about follicular carcinoma, and the important thing to remember here is that we are breaking through that capsule. It's the only one that breaks through the thyroid capsule and then routes hematogenously to the bone and the lungs. Next, we talked about medullary thyroid carcinoma. What's important to remember here is that there's going to be a lot of amyloid in our stroma that stains with Congo red, and of course when we stain with Congo red we will see green apple birefringence. Also key to remember the association with MEN2A and MEN2B here. Then finally we talked about our undifferentiated anaplastic carcinoma. It's going to be the only one that is really undifferentiated. It's going to present with an enlarging neck mass. That's also pretty unique, and it of course has the poorest prognosis, and it is the most dangerous thyroid cancer to have. Well, how did they ask you about this on a board style question? Something they might ask you is, a 56-year-old patient is referred for a concerning thyroid nodule. He receives a fine needle aspiration and histology reveals orphan antinuclei and psammoma bodies. What is a risk factor for this particular form of thyroid malignancy? Okay, so our patient received a fine needle aspiration, which of course is the diagnostic test that we need to determine if this is a malignant thyroid nodule or not. They had orphan antinuclei and psammoma bodies. That is very consistent for the presentation of papillary carcinoma. And then the question goes on to ask us, what is a risk factor for this particular form of thyroid malignancy? And at this point, I would go looking through the patient's question stem. I would try to see if it mentioned anything about a specific RET or PTC rearrangement, a BRAF mutation, or childhood irradiation. If there's any mention that this patient has a past medical history of some sort of brain cancer or some sort of head and neck cancer that they received radiation for as a child, that I think would be your best bet as to what a risk factor for this patient's papillary carcinoma would be. Now I hope this video was helpful, and I'll see you next time.